Hi, this is Dr. Nick with the ECG Academy, and we're going to finish up this section on premature beats, talking about my very favorite, and that's known as other premature beats. Well, I didn't know what else to call this chapter, but we're going to start talking about a few things that you see now and then, including aberrantly conducted APCs, non-conducted APCs, and junctional premature beats, and something else, a special secret guest that's going to be coming at the end of this discussion. So let's start right off the bat. We're going to look at this tracing right here. Let's look at this as a chalk talk, okay? You look at the forest first, and you can see that there's some irregularity going on. In fact, it kind of looks like group beating, but the two beats are different. So it makes you think of those PVCs. You have a narrow beat and a wide beat, narrow beat, wide beat. Then you've got a couple of narrow beats in a row, another wide one, a narrow and wide. And you see that the wide ones are always premature. That's right. If you map out this normal-looking beat with a P and a QRS, your PR interval looks pretty normal. And if you take this one as the next normal beat and you look right in the middle, you can see that this beat right here occurred early. Now let's look at the QRS duration. In the normal beat, it's only about 80 milliseconds or so in duration. This QRS starts on the first row of boxes and finishes on the fourth row. So that's 3 small boxes, 120 milliseconds. So it's clearly wide, it's clearly premature, and you'd say, well, the QRS complex looks really quite different than the underlying rhythm, and this kind of looks like a PVC. So you'd look at this and say, well, it's every other beat, so it's ventricular bigeminy. Isn't that right? Well, if that's what you think it is, I'm going to show you why it's not. If you look at these two normal beats in a row, it gives you a chance to look at what the normal T wave looks like. And the normal T wave looks pretty smooth, as T waves should. And then you have this P wave that occurs before the normal QRS complex. So the P's look fine, and the T looks pretty smooth. What you need to make sure about is that there isn't a P wave in front of these wide-looking beats. And if you look at this T wave right here, it looks distinctly different than this T wave here. Why? You guessed it. This is a P wave, and so is this. Well, you'd say, well, that looks like a normal T wave to me, but it looks different from this T wave. Okay? You have to compare from one T to the next. So now if you look at this T wave and you look at this T wave, you can see that this one's much more bumpy. There's a big giant lump on top of that. It looks like Mount Everest to me, and that's the P that results in this wide beat. And so what are these beats? These are known as aberrantly conducted APCs. They're aberrantly conducted because the premature beat, this P wave, got through the AV node and encountered partial refractoriness of the conduction system below the AV node. So if the AV node is here, and you've got your left bundle and your right bundle, and your hemifascicles going down here, so the premature beat gets down just at a point when one of these hemifascicles is blocked. It hasn't recovered from refractoriness. Remember, the right bundle can have a longer refractory period than the left bundle. And if this beat comes down right at this location, it may be able to conduct down the left bundle, but the right bundle is blocked. And that gives you aberrant conduction, or a functional bundle branch block. So timing is everything. This P wave happened to occur at a point when one of the bundles had not recovered from refractoriness, and you get aberrant conduction or a functional bundle branch block pattern. Okay, and you're going to see this again and again, and in fact, I'll bring it up again when we talk about supraventricular tachycardia, because frequently that'll occur with aberrant conduction, and then it's hard to tell it from ventricular tachycardia. It's one of those challenges that only ECG experts can solve, and that's why you're watching these videos, isn't it? Well, now that we've covered aberrantly conducted PACs, let's go on to the next topic. Here's an interesting rhythm strip that I found, And you can see that the rate's quite a bit faster than the last cardiogram. The fine lines are kind of difficult to see, but I think if you count off 300, 150, 100, it's just about 100 beats per minute. There's a nice P wave with a normal PR interval of about 140 milliseconds. And so you have sinus rhythm at 100 beats per minute. In fact, I think it's right on the border of 100. Each of these QRS complexes seems to land in the same position with respect to the heavy line. Okay, but then all of a sudden, you see slowing of the heartbeat. The R-to-R intervals suddenly become much longer. You still have P waves here in front of every beat, but there seemed to be a sudden slowing of the sinus rhythm. And you've got this period of slowing down here, and then suddenly the sinus rhythm seems to pick up again, and it goes back to where it was before. And so you have to kind of ask yourself, well, is this a sinus node problem? Do we have sinoatrial exit block? That would be a possibility, because here you have sudden slowing of the sinus node, so potentially these sinus impulses couldn't get out to the atrium. So that's a possibility, but that one's not right either. And again, the key is in the T waves. Look at these T waves. They look very smooth and very consistent, and then suddenly this is Mount Fuji over here. It's Jaigundo. And why is it Jaigundo? And why is it followed by slowing of the ventricular rate? Well, that's because right here is a P wave that did not get down the AV node. It's non-conducted or blocked. We call this a non-conducted PAC or a blocked PAC, and it left a pause in the rhythm, which is really just a compensatory pause. You remember atrial premature beats result in compensatory pauses, and they sometimes can conduct with a first-degree AV block, but in this case what's happened is this PAC landed at a point where the AV node didn't have a chance to recover from this beat. So this lands on the refractory period of the AV node and fails to get down the AV node, so you're left with a pause. Okay, so then here's the next sinus beat, but then it happens again. This T wave is again very tall because there's a blocked PAC, non-conducted P wave, that creates this pause in the rhythm, and then it happens again. You've got another P and then a non-conducted PAC here. Well, every other beat is premature, so it's definitely bigeminy, and it's atrial bigeminy, but these atrial bigeminal premature beats are non-conducted or blocked. And so it's a non-conducted atrial bigeminy, and it sets up this pattern of conduction and block and conduction and block. And then finally, this beat conducts, and look, the T wave goes back to normal because now there's no PAC here, and the next sinus beat comes on time. And so the sinus rhythm starts to conduct one-to-one, because this atrial bigeminy goes away, and then you're back to where you started. So the idea that you can have non-conducted or blocked PACs in a bigeminal pattern, that's a kind of a cool thing, and it fools a lot of people. So you've learned two things from this trip, that you can have non-conducted PACs. Now, I prefer the term non-conducted rather than blocked. A lot of people call them blocked PACs, but because these PACs are so early, look, if you just measure the rate between this PAC and this PAC, it's about 150 beats per minute. And a lot of patients will not be able to conduct that quickly after this one. So in reality, it's normal physiology for the AV node to act as like a safety valve, to not let rapid atrial rhythms down. We'll see that when we start to talk about atrial tachycardia and other atrial arrhythmias where the AV node actually protects the ventricle against rapid atrial arrhythmias. But in this case, it's kind of a normal physiology to have this premature P fail to get down the AV node. And so the word blocked implies there's something wrong with the AV node, and often that is not the case. So I prefer the term non-conducted. It just is more clear and less misleading, and doesn't make it sound like there's something wrong with the AV node. Okay? Let's go on to the next example of unusual premature beats. Now here's a 12 lead. It's kind of set up differently because you've got all the leads kind of like It's almost like a rhythm strip. You have V1 through V5 here, and then you've got some of the limb leads here. It's kind of a strange setup for this particular ECG machine. But if you pick any lead, you can actually see that there are P waves in front of each beat, and the PR interval is fairly normal. And the rate here is maybe a little, maybe 78 beats per minute or so. So you've got a normal sinus rhythm at 78 beats per minute. And you've got 1, 2, 3, 4 beats that all seem to be normal. And then you've got this beat, and it's a premature beat. But when you look at the QRS complex, it looks very similar, if not identical, to the underlying QRS, to the conducted one. See, in V1, this is down. In V5, it looks a little bit shorter, but it's almost identical in every single lead that we're looking at. And so it looks like it might be an atrial premature beat. But when you look at the T wave preceding this premature beat, you don't see a P. This T wave looks exactly the same as this T wave. There's no P preceding it. But what you do see is a P following that beat, and it's inverted. In fact, you can see that it's a retrograde P. That means it came from below and it's traveling upwards towards the sinus node. Well, what does that mean? If the beat looks almost exactly the same as the normal beat, but the P wave comes later, you have to think of normal physiology here, and I'm just going to try to get you to understand what's happening. Okay, if here's your AV node, and you've got your bundle branches going down, the QRS complex looks like it followed the normal bundle branch system because it looks the same as the underlying beat, but the P wave was retrograde in that it started down in the lower part of the atrium and traveled upwards. And so the beat must have arisen from somewhere in the AV node. Somewhere in the AV junction, this beat occurred, and then it traveled down rapidly down the Purkinje system to give you the QRS complex, and then after a short delay, emerged out these transitional fibers to the atrium and gave rise to a retrograde P wave. And we call this a junctional premature beat, or JPC for junctional premature complex, or contraction. So this is an example of how an ectopic beat can arise from the AV node and give you a QRS that looks almost exactly the same as a normal beat, and yet there's a retrograde P wave that follows it. Okay, now just to let you know that sometimes these junctional premature beats can arise from a little higher up in the AV node. For example, if the beat arises from the top part of the AV node, it will emerge from the AV nodal complex first and then manage to get down the Purkinje system. So junctional premature beats can sometimes look like this, with a retrograde P wave just in front of the QRS complex, usually with PR intervals that are way shorter than 80 milliseconds. But sometimes what you'll see is a junctional premature beat that looks exactly like the underlying QRS, but no P wave visible. And that's because it arose from the middle part of the AV node and wound up going retrogradely and antegradely down the His bundle system at the same exact time. So the P wave is actually buried in the QRS complex, and you just don't see it. So these are three different forms of junctional premature complexes, and you'll see it now and then, but it's kind of a rare finding. Okay, the last thing I want to show you is this very interesting ECG. And if you scan the forest, you can see that for the most part, it's fairly regular, except that there are these premature beats every now and then. It's regular, 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 and then you have a premature beat. Now, does the premature beat look exactly the same as the underlying rhythm? No, it does look a little bit different. In fact, if you look at this beat here in lead 3, it's going in the opposite direction from the underlying conduction system. So it does not look like a junctional premature beat, but yet there's no P wave either before or after it. So what is this beat? Is it coming from the atrium? Is it coming from the ventricles? Well, let's take our calipers out and see if we can figure out what's happening. So if we take these calipers and we put them on top of a P wave and establish what the P to P interval is, that helps us a lot, because then when we move it over to the next P wave, we see that the sinus beat should have landed right about where this QRS is. And then if we measure on to the next beat, we see that this P wave occurs on time. Sometimes, in fact, it's helpful to look at two P waves. So let's stretch our calipers out here so that we're spanning two P waves. Okay, so that's the beginning of two P waves, and you can see that that's pretty consistent. And if you look at the next P wave here, you can see that it lands right on time. But when you measure from this preceding P wave, you can see that this one, in fact, is on time as well. So if there's a sinus P, it's buried in the QRS complex. I think, in fact, you could probably see a little tiny piece of it right here at the tail end of the QRS complex. I think this sort of like little bump after the QRS is, in fact, the sinus P going on. Well, could that sinus P have caused this QRS complex? Obviously not. The P can't conduct at the same time. Could this be a junctional premature beat? No, I don't think so, because it looks so different from the underlying QRS complexes. What we're dealing with here is a premature beat that arose from the ventricle. It's a ventricular premature beat, yes, but it had to follow part of the normal conduction system because it's so narrow. It's really very narrow. In fact, it's not much wider than the underlying QRS complex. If we were to create some space here and then draw a little heart, my very fancy conduction system heart. Okay, so if the conduction system, if you have your AV node and you have your bundle branches, you got the right bundle here, you got the left bundle, which is much heavier, splits into hemifascicles. Okay, now where did the beat come from? It had to arise somewhere down in the bundle branch system. Maybe the right bundle branch, maybe one of the hemifascicles. Okay, but it must have arisen from part of the conduction system. And then what happens is it follows that conduction system out to the rest of the heart. But the premature beat arising from this part of the conduction system would have to go back up in a retrograde direction, reach the His bundle, and then turn around and then go back down the opposite bundle. And so what happens is it gives rise, in this case, to a little R prime here. So you have like an RSR prime pattern. It's like an incomplete right bundle branch block pattern. I talk about bundle branch block patterns in the intermediate course. When you're reading 12-lead ECGs, of course, you need to be able to recognize this. But the point is that beats can arise from part of the conduction system, and then what happens is they can wind up taking an aberrant course through the conduction system and give rise to a slight widening of the QRS complex, but not a full-blown bundle branch block pattern. In fact, it's conceivable that this beat arose from just below the His bundle, somewhere in the left bundle branch. So if it arose from the left bundle branch, just below where the two branches split, it didn't have to go far to get down the right bundle again. And so instead of having a narrow QRS complex, what you get is a little bit of an aberrant conduction. It causes the QRS to become a little bit wider, but not quite so wide that you can call it a true ventricular premature beat. But in reality, it's arising from below the AV node. And so what I like to call this is a narrow VPC, or you can even call it a hemifascicular premature beat, because it's arising from the Purkinje system, it's arising from the conduction system itself. Now, this is kind of unusual, but I just want you guys to think about the physiology, think about where these beats are coming from, and keep in mind that they don't always look like the textbook. If you understand the physiology, you can figure out what it is. You have to use your brain, you have to analyze the signals and the tracings, but eventually you can look at something and know what it is because you understand the physiology. And on that note, I'll end this discussion of premature beats, and we'll go on to the next section and start talking about atrial tachyarrhythmias. So, for the ECG Academy, this is Dr. Nick. Thanks for watching.